Welcome, everyone. I'm going to give everybody a few seconds to join us here. So we've got lots of people coming in from our waiting room. Welcome, welcome. Awesome. While you're joining, what I'll get you all to do is, as a bit of an icebreaker, click on that chat button in your Zoom toolbar and let us know where you're tuning in from. My name's Troy, and I'm the Director of Operations for Nurses Specialized in Wound, Ostomy, and Continence Canada. And we're excited to be delivering another Wound, Ostomy, and Continence continuing education webinar today. We have a great guest speaker who I'll introduce in just a moment. But we're going to be talking about Beyond the Incision, enhancing C-section recovery with single-use negative pressure wound therapy. And before we get started, I'll just go through a couple housekeeping items. First things first, my name's Troy. I'm a Director of Operations. As I said, I'm from Ottawa, Ontario. I see we got people from Peterborough, from Sudbury, from Toronto. Type in that chat. Let us know where you're coming in. New Brunswick, Hastings County, Ontario. Fantastic. We're so thankful to have Smith+Nephew be able to deliver this education today. We appreciate their support and their ongoing partnership in delivering these webinars. It's been fantastic. We're going to be recording today's presentation, so if you aren't able to stay for the entire duration, or if you or a colleague want to be able to watch this back after, it will be available on our NSWOCC.ca website. Everyone who's online today will be also receiving a certificate of attendance, so don't worry about that. We'll make sure to get it into your inboxes within the next couple of business days. And we are going to be holding a Q&A portion at the end of today's webinar, so we'll encourage you to use the Q&A box, so not the chat, but the Q&A box to post your questions. That'll keep it organized for us so we can get to as many as possible towards the end. So with that said, I'm happy to introduce today's presenter. It's Sebastian Hobson, and Dr. Hobson specializes in maternal fetal medicine with expertise in labor and delivery, complex obstetric surgery, and placenta accreta spectrum disorders. He completed his medical training at Monash University in Melbourne, including a master's in public health and a PhD in preeclampsia. After training in Australia, Dr. Hobson moved to Canada to join the maternal fetal medicine division at the University of Toronto and currently leads labor and delivery at Mount Sinai and serves as co-chair of the Clinical Practice Obstetrics Committee for SOGC. So without further ado, I'm very happy to hand over the mic and the slides to you, Dr. Hobson. Thank you so much for being with us today.
Thanks, Troy. I really appreciate it. Thank you for the introduction. And hello, good afternoon, good evening, everybody. Thanks for joining. Troy told me that there's a hockey game on tonight, so we have to turn an hour presentation into a 15-minute presentation. So get ready. We're going to fly by the seat of our pants through C-section recovery with single-use negative pressure wound therapy. Troy's very kindly introduced me already, but I do work in obstetrics and MFM. I work at Mount Sinai. We do about 7,500 births a year. So we're quite busy, and about 1 in every 3 babies is born by cesarean section. And that's pretty in line with the Canadian stats at the moment. I work a lot in labor and delivery, and I run a complex obstetric surgery fellowship for graduates each year. And work across a number of sort of committees, really focused on education and evidence-based medicine. And so I love to see changes in our practice. And I think it's a shame when we get stuck in our old ways of doing things and don't keep changing our practice. So this is a good opportunity to talk about some changes. And as Troy said, I work across all sorts of areas within complex OB surgery, including doing a fair few cesareans for patients with elevated BMI, which is what we're going to focus on today. So the learning objectives are to talk about the clinical evidence and the indications for single-use negative pressure wound therapy in the cesarean section patient, talk about what are the risk factors that increase our susceptibility to postoperative wound complications. And you would know most of this better than I do. For our team at Mount Sinai, our godsend is the nursing team who really manage all of our postoperative wound complications and troubleshooting and issues. And so for sure, this is a really interdisciplinary approach that we need to come at this from. We're going to talk about how standardized wound care protocols could be used in your centers for cesarean section patients, and talk about some of the international guidelines that are coming out to align with the new literature. So If we take one of these guidelines as an initial example, I want to bring your attention to the Enhanced Recovery Canada clinical pathway for cesarean delivery. And this was published just over 2 years ago now. The leading author was Jackie Thomas, an obstetrician from Toronto. And they really showcased all of the latest evidence for our approach to cesarean section to enhance recovery for patients. And obviously, it included intraoperative and postoperative care. So there was a number of changes in this, but the last one in the list that was of the major ones was prophylactic negative pressure wound therapy in patients with class 3 obesity. And I think we can go by in our careers and not be aware of many of these changes in guidelines and practice, but I think Enhanced Recovery Canada is doing an amazing job to help us along the way and really synthesize this huge volume of literature. So when we consider cesarean births in Canada, I talked a little bit about the C-section rate. We try to collect our data through Chi-Hi in the best way that we can, but we find that a lot of our data is a couple of years behind. This is our rate from 2019 showing about a 30% cesarean section rate and that would account for over 100,000 cesareans per year in our country. It's the number one inpatient surgery in the childbearing age group, and the average length of stay is about 3 days for our patients. We are lucky to have some local data from Hamilton showing that the risk of surgical site infections after a cesarean section in Canada ranges from about 3.5% to up to 6%. And so this is a significant number of patients who end up with a cesarean section wound infection. But when we think about surgical site complications, it goes far beyond infections and includes wound dehiscences, seromas, hematomas, or poor or abnormal scarring. And these are all of the things that we're thinking about in our surgical approach and postoperative care for patients with a cesarean section. But when we hone down in on infections as an adverse outcome, it's more than just a wound infection. It's occurring at a life-changing time for these individuals where they're having sensations of perhaps pain or discomfort or bleeding or discharge that's going on, and maybe they're needing to take antibiotics and whatever the sequelae is of taking those antibiotics, yeast infections, gastrointestinal upset. They're having to do their dressings and wound care, and nobody knows this better than all of you. And maybe they even need to go back for admission or reoperation with debridement, but certainly additional follow-up. In the US, they've tried to stratify the cost of what a surgical site infection means, and the incremental increase in cost is about $4,500 per patient who gets a wound infection on average. Some of them get poor healing and some can have really poor cosmetic results. And the self-esteem and psychosocial impact of a wound infection is far beyond what we see as the tip of the iceberg. And really what I want to highlight is through all of these mechanisms, there can be interference with feeding and bonding and separation from their newborn infant during such an important time in their lives. And so whatever we can do to recognize the problem, identify the risk factors, and then find effective treatments, let's do it all together. So for a second, for those of you who work in institutions or hospitals, clinics, I want you to think about how are the ways in which you capture wound infection rates in your institution. So if I think about my institution as a place who does cesarean sections and how we capture surgical site infections, I think it's really, really challenging. And I think we don't even scratch the surface of capturing all of the wound complications that we have. Because after a patient is discharged from their cesarean, they're not always going to come back and see us for their wound complications. they're going to see you, they're going to see their family physicians, they're going to see other providers, they might go to emergency departments, not even at our hospital. And so we lose all of this data capture. So we have to be cautious with the way that we interpret all of this because it's not a closed loop. And sometimes we're lucky, sometimes we see them at 6 weeks and close the loop and find out all the information. But what then is the data capture like? And is it comprehensive? So we've got a problem here with the data collection, but at least we can recognize that and think of ways together that we can improve it. So thinking of risk factors, there's been a number of papers published, and to think about it, I've shown you our rate of wound infections or surgical site infections in Canada after cesarean is somewhere between 3.5 up to 6%. But this was out of the UK. For all comers, their surgical site infection rate at cesarean section was overall 9.6%, and that's in a slightly different population. They had higher rates, and maybe they capture it better than we do. But as soon as you add some complicating factors to that patient, for example, diabetes, their rate shoots up by about 50%, up to 15.6. And BMI is an extremely important risk factor for surgical site infections after cesarean. And when patients have a BMI of 35 or above, we see a rate of 1 in 5, so 19%. And that's a linear relationship that goes hand in hand with BMI rising and surgical site infections rising. So BMI is very, very important to us in the C-section world. It's echoed by other studies. This one's out of Australia, secondary analysis of an RCT of negative pressure wound therapy in C-section patients with a BMI above 30. They showed that 15% of their patients have a surgical site infection and surgical site complication, and a few more details there. But having had more than one previous cesarean section is a risk factor, as well as ruptured membranes more than 12 hours. So when we think of the standard dressings that we use for cesarean section, we've got a number of benefits of those standard dressings. So it acts at the wound surface and provides a very nice barrier and sometimes can take away some of the exudate. But when we think of negative pressure wound therapy, there's a number of mechanisms of benefit that probably contribute to a lot of the evidence that I'm going to share with you. So it's also protecting the incision from the external environment. We're getting some extra removal of surface drainage compared to standard dressings. We're getting more resistance of gaping through decreased lateral tension because the dressings are on for 7 days rather than off within a couple of days. And we're getting a number of benefits from this. So it's multifactorial mechanisms of action. So to summarize the evidence in this patient group getting cesarean section, and particularly in patients with an elevated BMI, we want to go to the literature and have a look. And so these are the 4 sort of most relevant topical papers that I wanted to share with you. The first in the top left corner is looking at single-use negative pressure wound therapy versus conventional dressings for all closed surgical incisions. So not just cesarean section, but other types of closed surgical incisions as well. I wanted to then share with you in the top right-hand corner a randomized controlled trial of cesarean section outcomes with single-use negative pressure wound therapy in patients with an elevated BMI. Then down in the bottom left corner, I'm going to walk you briefly through a cost effectiveness analysis of what does it do to healthcare costs when you use single-use negative pressure wound therapy. And then finally, the sort of largest and most recent systematic review and meta-analysis for use of this technology with cesarean section in elevated BMI patients. So the first of these papers was by Saunders, looking at meta-analysis for all closed surgical incisions using negative pressure wound therapy compared to standard care. And what they showed from these 29 papers of 11 RCTs, 18 observational studies, 5,500 patients, they looked at all of their different types of surgical site complications. and length of stay. And what they showed is that for use with closed surgical incisions, they can decrease the odds of surgical site infections by 63%, a 30% reduction in the odds of dehiscence, 77% reduction in the odds of seroma with a number needed to treat of only 13, an 89% reduction in skin necrosis, and a reduction in length of stay of over 1.5 days. And so all of these things are really important drivers of a number of changes in guidelines that I'll share with you in a little while. When they looked at their subgroup analysis of cesarean section only patients, this was 3 studies of nearly 3,000 patients, they really showed a 51% reduction in surgical site infection risk. And that was a significant finding. And so this was really the impetus for a lot of research and study into doing more investigation into the role of this technology. And that would bring us to the most relevant study for the use of PICO dressings, and that's by Hildig. What they did was a randomized controlled trial in C-section patients with elevated BMI, a multi-center randomized controlled trial in Denmark, where patients who had a BMI of 30 or above, who were having either emergency or elective cesarean section, they were randomized to PICO versus standard care, and they had just over 400 patients in each group. And what they were able to show was a 50% reduction in surgical site infections with a number needed to treat of 22, and a 31% reduction in wound exudate. So the most relevant randomized controlled trial to PICO use showing significant difference. When they did a cost effectiveness analysis from the same trial, so an economic evaluation of what difference this makes to economic cost, what they showed is that for all patients with a BMI above 30, that there was a $74 reduction in healthcare costs, and that's 74 Canadian dollars converted from euro. And for patients with a BMI of 35 or above, there was a $533 savings across the healthcare system, even taking into account the increased costs of the dressing itself compared to conventional therapy. And so it's really important for us in the Canadian context to think about it from that perspective, because we have a public healthcare system that cares for us very, very well, but we pay for it. And so these are really important factors when you're considering perhaps rolling these things out across your institutions if you haven't used them before. These can be very beneficial things to take to your P&T committees. And then finally, I wanted to go over the systematic review and meta-analysis, taking into account all of the recent trials of negative pressure wound therapy versus conventional wound care for cesarean section in patients with elevated BMI. This included 10 published randomized controlled trials, 5,500 patients, looking at the outcomes of infections, complications overall, and blistering. Because a few years ago, we started to get a little bit cautious of the use of single-use negative pressure wound therapy at cesarean section, because we were noticing a signal for an increase in blistering compared to standard care. And so this was really important to look at. So what they showed in this most recent systematic review and meta-analysis was overall a 21% reduction in surgical site infections when you use negative pressure wound therapy, but a 4 times increased risk of blistering. And so this signal that we saw made us think, hey, we're getting this benefit of 21% for surgical site infections, but we're a bit worried about the blistering. But when you go into these trials, we have to look in the detail of them, because as you all know, not all single-use negative pressure wound therapy is created equal. And I'm happy to talk about this in the Q&A, but for looking at some of the competitors, they're different technologies, they're not the same, and there's some really important differences in terms of how much pressure is used and the actual physical shape and physics of how it induces pressure on the skin at the adhesion site. And so when we look more in detail at those trials which investigated blistering, only one of those 5 trials specifically used PICO and reported blistering. And so that showed us that the meta-analysis for blistering is largely based on outcomes of alternative dressings. And so there's a number of reasons for that, but we have to be cognizant that we are probably going to have more blistering when we use negative pressure wound therapy, but it may not be as high as what the meta-analysis shows us if we use PICO. And this is the forest plot showing all of the trials that were involved, just so that you can have visibility to that. And the 4 contained within the red boxes are ones that used PICO, and not all of those obviously looked at blistering. So the last thing that I wanted to show you was some SCAR outcome data. And what we can see for this trial, also by Hildig, is that at patients assessed at 30 days, 6 months, and 12 months, from PICO compared to standard dressings, we see significantly improved outcomes for patient satisfaction. And for those individuals who are using staples for wound closure at cesarean section, we have significantly fewer hatch marks for PICO use versus standard dressings. So that's really a whirlwind tour through the evidence for why we think the way we think now, and things are changing the way they are. It's been best embraced by our Enhanced Recovery Canada guidelines, but even before those were published, these were the NICE guidelines from the UK. And we pay a lot of attention to these because we have a lot of correlation with the UK evidence base. For some things, we engage the US base, but we know that sometimes there's differences. And so when NICE does something, we tend to sit up and pay attention. What they've done is had 2 updated guidelines. What they've recommended in those across the UK is that PICO negative pressure wound therapy should be considered as an option for all closed surgical incisions who are at high risk for developing surgical site infections. And that's because of a number of benefits that we've talked about. And then more specifically related to cesarean section, they recommended that single-use negative pressure wound therapy be used for patients recovering from cesarean section with a BMI of 35 or greater. And that's well based on the literature that we've discussed. And so now we're starting to move in a similar direction and see this change translate into clinical practice across our country. So when we consider ways in which we can use this evidence and use these guidelines to improve patient care, it can often be best achieved by using a management pathway within your organization. This is one example of a risk management pathway that we often utilize in my center. But it needs to be individualized to your patient population. It needs to be individualized to who's paying for the dressing. It needs to be individualized based on, obviously, provider preferences and also what arrangements you have with companies to get these resources. So we do a preoperative risk assessment in our evaluation of patients. So you can see it involves an assessment of body mass index, if they have diabetes, an assessment of their control, an assessment of whether they're affected by an immunocompromised status or suppressed condition, whether that cesarean section was emergency or elective, whether they've previously suffered from a surgical site complication or infection, or whether it's been particularly prolonged or complex surgery. So for an example, in my practice, we do a lot of cesarean hysterectomies for placenta accreta spectrum. It can take us 3 or 4 hours to do these surgeries, and sometimes they can have excessive blood loss. And so we use a PICO dressing for all of our patients who have those prolonged or complex surgeries. And then we define them as high risk or low risk, and then assign an appropriate dressing for that individual and what their needs are. So the last sort of thing I wanted to finish on was a case study just to show another area where we use this. And the use in patients with an elevated BMI is important, but it comes as a bundle. It comes as a quality improvement package with a number of different changes in the way we care for these patients. And it's based on well-published guidelines. In Canada, we have two guidelines from SOGC, which are getting due for renewal soon. They're almost 6 years old. And it's these guidelines which help us to bring these into our practice. So I'm going to walk you through a number of different ways in which we conduct a cesarean section for patients with an elevated BMI. And part of this package and bundle is the wound care management afterwards with an appropriate negative pressure wound therapy. So to give you more clinical context, the way we start is very important. Not all C-sections are created equal and not all skin incisions are created equal. So gone are the days of doing a low fan and steel bikini line incision for everyone with a cesarean section, because as we know, most of us have got a little pannus going on, and underneath that pannus of our abdomen, it's hot and it's not dry and there's more bacteria. And if we're going to deliver a baby, why would we deliver a baby through the exact area of skin underneath the pannus that is at the highest risk of getting surgical site complications? And the other thing that we know in individuals with a particularly high BMI is that all of their anatomical landmarks are changed. Gravity makes the pannus move down, makes the umbilicus move down. And so when we consider where the bony pelvis is, sometimes the skin landmarks on top of that are in very, very different locations. So we may be able to approach the lower segment of the uterus from a different skin incision, and that's where ultrasound comes in. So what we do is we tend to steer very clear of a fan and steel incision. We tend to steer clear of that increased risk of wound infection and complication, and we use ultrasound to help us. So we feel the ASIS, we feel the bones of the anterior hip, and that's sort of in line with the area we want to go in. Then we follow it around onto the anterior abdomen, and then we start to use ultrasound at that site. And what this image is showing is we're using ultrasound around the umbilicus, below the umbilicus, above the umbilicus, to measure what is the thickness of the subcutaneous tissue in this area. And what we find is that we're in the right location to get down to the lower segment, and we're working out, we're going to do a much higher horizontal incision on the abdomen. We're nowhere near the pannus, and we're finding the thinnest distance to the target. So for this patient, they're a 30-year-old gravida 2 para 1. They have a BMI of 70. That's a very common thing that we see in our center. One prior cesarean section, and you can see the prior cesarean section scar up the top above the belly button. And the patient elected to have a repeat cesarean section for delivery. They didn't want to try and have a TOLAC. And so we performed the same ultrasound that we did for the previous time. Now, to help illustrate what happens during the surgery, this is where we're bringing in a number of educational resources and tools. And one of those, as an example, is TVA Surge, the Toronto Video Atlas of Surgery, where we freely publish all of our surgical education videos across all aspects of surgical care and disciplines. One of the tabs here is in obstetrics, and so we would click on that. And within the obstetrics folder, there's a video on our modified approach to cesarean section. And I'm going to play for you some of the aspects of this cesarean section. So you can see we're above the belly button. We're going down through the previous incision, a really seemingly random place and a really different place to what people may be used to doing cesarean sections, but a much better location for postoperative recovery afterwards. We get some people thinking that if they have a much higher incision on the abdomen, that they're going to have a worse recovery, they're going to have more pain. And what we actually find is that compared to those patients who have an incision really down low on the abdomen, when it's much higher, they've got a lot less pressure on that location. And so their recovery is so much easier when we're in a more appropriate location. So we're working our way through all of the layers here. Getting down to the uterus, making sure there's no adhesions going on. I think for this patient, there was a small adhesion that we got rid of. And then we use some other technologies like putting in a Mobius retractor so that we have more exposure inside the abdomen. But there's a number of other self-retaining retractors that can be used and that are very, very effective. And this gives us more space to see what we need. There's that little adhesion from the previous cesarean section that they're getting rid of. And now we're down to the uterus. So going down through the layers, I know for many of you, this may not seem relevant, but I hope it's fun and interesting to see the approach. And I think still it's always for me beautiful to see a baby being born. So I hope you're enjoying. They're just in extending the uterus incision, going inside the uterus to find baby, and then bringing the head out. So here we can see baby's head emerging from the uterine incision. Lots of nice hair for this baby. And then baby's born. So after that time, we're going to cut the cord and then we're going to deliver the placenta and then we're going to start to close the uterus. The uterus is closed in layers. Then we're working our way through closing the rectus sheath and the peritoneum. Still closing. Then we're down to closing all of the subcuticular layers. It's really important to close the dead space if it's in a measurement of more than 2 centimeters. And then it's really important we're moving away from staples in our wound closure in obstetrics because there's much better wound outcomes for using a subcuticular stitch. And there's our pico dressing going over the top in the appropriate way and being activated. And these patients stay with a pico for 7 days after the delivery, and they are given all of the instructions for self-removal. You need to look in your area where you're working about what's the approved ways for removal. Sometimes it's by a provider and sometimes the patients can do it themselves. But there's a number of different resources online to help them with troubleshooting. That's the wound at 7 days. It looks unbelievable, fantastic. Believe me, it would look different if it was underneath the pannus. And then we're going to get a view at 6 weeks, and that's a second repeat cesarean section scar above the umbilicus. So really, really lovely wound healing with that model of care. So this is really bringing me to the end of my presentation. I've tried to keep it short and sweet, and you know that I'm happy to answer any questions. But what I want to do in summarizing this is that cesarean sections are an extremely common surgery, and we need to know about what's the best ways that we can identify risk factors for these patients for avoiding surgical site complications. We need to acknowledge the new literature and be open to changing our practice, particularly for patients with a BMI above 30 to 35. Single-use negative pressure wound therapy is a really lovely thing to reduce wound complications for them. It looks like it's got very nice cost effectiveness data to back it up, and we're seeing a lot of changes of our guidelines all across our country and others. And so this is where we need to embrace the change. And I'm very thankful for your time and very happy to answer any questions. Thank you.
Well, thank you so much for taking us through that. And I think I can echo what Sherry's saying in the chat here, which the video was so fantastic too, and the animation as well. Very, very interesting to be able to show that. We definitely do have a few questions here. So maybe we'll touch on a couple. Let's start with this one here from Farah, who was asking about how long a hematoma above the C-section site might be able to be left without treatment. Are there surgical options available if it continues to bulge?
So our general practice, it's a very good question, by the way. Our general practice is to, if a hematoma measures less than 5 centimeters in size, we generally don't do very much about it, and we let them heal all by themselves without any intervention. But if a hematoma is more than 5 centimeters in size, we want to get onto that sooner rather than later. So if we see them afterwards in our clinic or the emergency department, we tend to probe the wound, find out the extent of where it goes to, and evacuate as much as we can very gently in the moment, and go from there. But for something that's expanding rapidly, big, we want to move on it sooner rather than later.
Thank you for touching on that. And a question that someone had, I guess, more generally here, given risk factors like diabetes or a BMI over 35, this person's asking if you might want to comment on should there be a stronger focus on preventative measures rather than treatment? They're talking about potentially prioritizing health education, follow-up care. I'm not sure if you have any comments or general thoughts about that.
So I think this anonymous attendee is touching on something that we all agree with 100,000%. Um, I think elevated BMI, which goes hand in hand with risk of diabetes and a number of other metabolic complications of life, is one of our most important preventable healthcare needs of our entire society and impacts everything from, um, childhood outcomes to pregnancy outcomes, to mental health outcomes, to life expectancy, cardiovascular health. The list goes on and on and on. And so I think the answer to their comment and question is absolutely yes. There is no doubt about that, that we should be focusing on lifestyle modification, but that is an extraordinarily huge mountain to climb and something to overcome. And we should all be working on this and learning from other countries which may be doing things which we could benefit from ourselves. But it doesn't mean that we shouldn't be tackling the problems that are right in front of us now. And so I think it's a two-pronged approach where we take a preventative medicine approach, but we also take an evidence-based therapeutic approach as well. Great question.
Thank you for touching on that. I'm going to go to this question because we had another question in the chat as well on the same subject, and it was about the type of DM. Does it matter? For example, does gestational diabetes versus type 1 or type 2, is that just as much of a risk factor?
So what it actually comes down to is blood sugar control. And so that's why in our clinical care pathway, we focus on patients with uncontrolled or suboptimally controlled diabetes. I think someone with gestational diabetes, as an example, where it's extremely poorly controlled and they have high sugars all the time and they may be non-compliant with diet or exercise or insulin, or maybe they just have really hard to control diabetes, versus someone who's got beautifully controlled type 1 diabetes. Perhaps they have a pump, perhaps they have continuous monitoring, and they have a normal body mass index and are in all other intents and purposes, a healthy individual. I think they will still have better outcomes than that gestational diabetic with really poor control, and it more comes down to control.
Gotcha. Well, thank you for touching on that because I know there was a couple questions that came up there. Next question that I have here is about, let's pull this one up here. Infected C-section wounds are often very painful for most women. Besides medications or narcotics, what do you recommend, or do you typically recommend anything else like different types of gel in the wound for pain relief? Is this something you come across often?
Yeah, we don't use any of the lidocaine gels in the wounds. I don't know of the evidence around this. I've never ever seen it. I think it's a really good question. And if any of you have experience with this, I'd love to learn from you. But we tend to manage with simple analgesics, making sure that that patient is on a non-steroidal anti-inflammatory as an absolute priority. When we look at narcotics, only about 20% of patients after a cesarean section require opioids in the postpartum period or at discharge from hospital. And so that's 1 in 5 patients can have a tough time, but we need to focus on simple analgesics and every now and then opioids. But I think it's an opportunity to learn for alternative measures.
Thank you for answering that. And going on to the next question here, and this is more specific to our NSWOCs as well, but does your OR nursing team use a pathway for single-use negative pressure wound therapy to identify candidates? Do you work with NSWOCs where you work as well? Do they assess them preoperatively? What kind of experience do you have with this?
In our institution, all of the decisions still fall on the attending staff. And we have really tried to make our institution as welcome to change and as evidence-based as possible. So because we're a tertiary centre, we have a lot of trainees, we do a lot of teaching. attendings are not left usually to their own devices. So even though they're making decisions about what ultimately happens with that patient, they're held to account by the fact that they're surrounded by learners and other staff and nursing staff seeing all different types of practice. And so what we have done is we've built in pathways for example, elevated BMI patients that includes the use of negative pressure wound therapy in this. Um, I don't know about how much engagement there's been with NSWOCC. I don't know that. It's a very good question. I'm sorry I can't answer it.
No, that's no problem. And I'm sure it varies from site to site or facility to facility. Another question we had here coming in was about maybe more specific to Pico here. Someone's just asking for a question about if Pico does stay on for 7 days. They just wanted to verify that there wouldn't be a need to change the dressing twice weekly. Is that from your experience that would be the recommendation?
Yep, the recommendation is to use a
Yeah.
single Pico for an entire 7 days, not to change twice weekly, and to use once for 7 days.
Perfect. And this person's asking, I think I understand this correctly here. Would you consider using the Pico for 14 over Pico 7 for higher risk patient groups, especially for longer therapy durations, or in the case that the wound becomes dehisced?
I wouldn't use it for 14 days if there's no complications, even if that patient is at particularly high risk, because at the moment we lack evidence. And I'm so committed to the evidence that until there's something to tell me otherwise, no, I wouldn't just anecdotally change to 14 days. I think once a patient has a wound complication, yes, there may be a role for extending use and going outside the standard of care, but not for routine patients.
Thank you for touching on that. And another question here came in. Would you say that a VAC dressing would be appropriate or as effective as Pico, or when which case would you maybe be looking at using Pico versus VAC for these types of surgical wounds?
My personal answer is no, I wouldn't use a VAC dressing for any of these patients. I would use a single-use negative pressure wound therapy, be it Pico or another, like Prevena. But no, I wouldn't use a VAC dressing for these patients, and we don't have evidence to say that there's benefit when you use a VAC dressing.
Fair enough. Okay, well, thank you for touching on that. And I'll remind everyone too, if you have any specific questions about Pico, or if there's any questions you had in relation to any of the products that Smith+Nephew could touch on, you can always ask them now for sure. We still have some time, but if you can also reply to the email that you're going to get post webinar here too, and we're happy to connect you to in that way. Another question I had here, I don't know if you wanted to could touch on this a little bit, is studies have shown that using a Alexis retractor can reduce surgical site infections. Do you know what the rationale is behind this?
So when you use an Alexis or Mobius retractors in these situations, can they protect the inside lining of the subcutaneous tissues for the duration of the surgery. And so there's less exposure to contaminants and bacteria. And so the wound stays more protected and less exposed for the duration of the surgery. And we think that's the rationale for that.
Fair enough. And in this situation, again, a little bit of a different question here, but if you see tunneling or undermining, would you still use Pico or pack the wound with AMD ribbon, soak with iodine? Sounds like a more specific case in this circumstance. But when we're talking about tunneling or undermining, would you still be using Pico?
I don't, and I use packing.
Perfect. Okay, thank you. Just opened up a whole full screen here, so let me close that so I can see back to the chats here. We're getting so many great comments. Thank you, thank you, thank you. I know someone said here the way they were able to educate and simplify it down for everyone to understand as well has been super appreciated. Transparent, fantastic videos. So I'll just echo these same comments. And as I keep talking for a second, I'll keep the floor open in case anyone has any last minute questions that we're happy to answer here. Again, we appreciate you going through the presentation and leaving some time for questions here. So kind of just fill some air here while hopefully anyone else wants to put in their last questions, feel free. But other than that, I will just say thank you, I guess, here, Dr. Hobson. That was fantastic. We really appreciate you taking the time to present today and to answer some of these questions. I'll remind everyone again, you will be receiving a certificate of attendance, and you can access this webinar as a recording later. So if you have any questions, reply to that email. Whether it's for us or for Smith+Nephew, we're happy to get you in touch with the expert who can answer your questions. But besides that, thank you so much, Sebastian. We hope to see you on at another educational opportunity in the future, and we hope you have a good rest of the evening.
Thank you. You too. Thanks for having me. Have a beautiful night, everyone. Bye.
Thanks, everyone. Have a great evening. Bye.